My name is Robert Lehardy. I'm a professor and a researcher at the University of Houston, Clear Lake. And for the past few years, we've been working on this project that I'm going to tell you about today, or this evening, I guess. Thanks for joining me to learn about our training to teach healthcare professionals ways to increase the comfort of patients with developmental disabilities. If anybody has any questions or if anything needs to happen, we can pause or we can stop. I'll take questions as we go, unless you think they're better to hold until the end. Okay. I must disclose that this work is funded by a grant from the Texas Council for Developmental Disabilities. So today I have a few learning objectives. First, I want to take a bit of time to discuss the healthcare experiences of people who are diagnosed with developmental disabilities, or DDs, as I'm now going to say for short. Then I want to discuss some of the current research to improve health outcomes for people with DD. And last, I want to tell you about this. Oops, somebody came. I'm going to admit them. I want to tell you about this training that we've created for healthcare professionals to teach them how to use simple behavioral interventions that could increase the comfort of patients with DD during medical visits. Before we talk about health disparities suffered by people with DD, let me just clarify that the term DD is an umbrella that covers these most commonly diagnosed disabilities, along with some others not shown here. And I mean no offense if the specific disability that you or a loved one experiences is not shown here. Now, in terms of health disparities, people with DD experience increased risk of obesity, diabetes, hypertension, cardiovascular disease, and even cancer. Now, regarding cancer, it's not that having a DD necessarily predisposes you to cancer, but rather researchers have found that people with DD are less likely to get PSA tests to test for prostate cancer, pap tests to test for cervical cancer, or mammograms to test for breast cancer. So, why do people with DD experience these health disparities? Crane and colleagues in 2006 created a neat little diagram that I want to walk through with you right now. Note that their research focused on people with intellectual disabilities, which is one type of DD. But once we look at the factors that contribute to health disparities, I think you'll be able to see why the factors likely affect more than just people with intellectual disabilities. So on the left side of this figure, we can see health status. And for example, here is the health status of people in the general population. And here might be the health status of people diagnosed with a DD. And that difference in the size of the bars between the two groups reflects the health disparity between these two groups. Now, Cran and colleagues then identified some factors that might increase health disparities, such as genetics, social circumstances, environmental conditions, health promotion, and medical care access. But what are these factors really? Let's dig a little bit deeper. Now, for the sake of time, I'm only going to go through one example to help explain what each of these factors is, but I'll share the reference for this article at the end so that you can read more if you want to. So, genetics means that a person's biology that contributes to their disability also contributes to other aspects of their poor health. So, one example of this is that people with Down syndrome also experience higher rates of thyroid dysfunction. Now, both Down syndrome and a predisposition to thyroid dysfunction result from having an extra 21st chromosome. And one of the most common forms of thyroid dysfunction is hypothyroidism, which results in weight gain, fatigue, depression, and other symptoms. And it is these symptoms that could contribute to health disparities for people with Down syndrome. Now, social circumstances refers to things like a person having a low socioeconomic status. So, low socioeconomic status can affect health in a variety of ways, But one example might be that a person can only afford to live in an area that does not have easy access to healthy food. And so as a result, they eat fewer healthy foods and they must eat more unhealthy foods. And over time, this dietary imbalance can lead to health problems that ultimately increases health disparities. Another interesting social circumstance to consider is when caregivers give inadequate attention to a person with DD about their medical needs. So, likely, this factor is made worse the more dependent the person with DD is on their caregiver. So, for example, a nonverbal autistic person who cannot express that they suffer from migraines may not get adequate medical care if their caregiver thinks that their migraine-induced symptoms, such as irritability or sensitivity to lights and sounds, is just another feature of their autism. So obviously, this may lead to the person with DD not receiving care for their health problem, which results in increased health disparities. Environmental conditions relates to things like being exposed to toxins like lead, or here in Houston, we have a lot of benzene, both of which cause health problems that could increase health disparities. Another part of this factor is that your environment may physically lack healthcare providers, which could make it impossible to access healthcare. This could definitely increase health disparities. And I have real experience with this. I lived in Omaha, Nebraska while working to earn my PhD, and there were frequent calls for physicians and other allied healthcare professionals to move west to the more remote parts of Nebraska so that people in rural areas could access care more easily. Health promotion refers to people with DD lacking knowledge of health behaviors. Now, there are many examples of this, but before I worked with healthcare professionals, I worked with children with DD. And lots of my kiddos would need help learning skills of daily living, like brushing their teeth. Because if you don't know how to brush your teeth and you don't know how frequently to brush your teeth, you will probably experience dental problems that result in increased health disparities. Now, last, we come to medical care access. This refers to people with DD receiving worse quality health care for multiple reasons. And this factor is what this whole project is basically about. So, why do people with DD experience inadequate quality of healthcare? Well, one important reason that not only affects people with DD, but affects everyone, is that we just don't have that many physicians out there. Now, these data that I'm going to show you are from the Association of American Medical Colleges, or AAMC. In 2023, in the United States, there were only about 1 million physicians. Now, I couldn't fit all of the different physician specializations onto this one slide. So these combined numbers don't add up to 1 million. But I did make sure to include all specializations that fall under the umbrella of primary care. Now, primary care physicians are the frontline physicians who typically see patients first. And it turns out that only about 360,000 physicians specialize in primary care. But this is a problem because DDs are quite prevalent in the United States. In fact, Zablotsky and Bloomberg in 2023 found that about 8.5% of American children, oh, sorry, in 2021, sorry, found that about 8.5% of American children were diagnosed with the DD. Now, this is about 6 million children who are going to be interacting with only about 360,000 primary care physicians. That means that in the US, children with DD outnumber primary care physicians by about 16 to 1. Now, this may not sound like such a horrible ratio, but one relevant question is how many of those 360,000 primary care physicians are specifically trained to accommodate people with DD such that they're able to provide the same quality of healthcare to that person as they can to a person who does not have a DD? Unfortunately, The research to answer that question isn't very comprehensive, so we aren't sure. But we are pretty sure that there is room for physicians to receive more training. For example, healthcare professionals report to researchers that they feel limited in their ability to medically care for patients with DD, and that these feelings may cause them to feel unqualified or even unwilling to care for patients with DD. Now, that is a big problem. In addition, numerous groups of healthcare students and professionals have repeatedly said they would like more training to prepare them to medically care for people with DD. This implies that there may not be enough training in existing training curriculums for students or physicians to feel totally comfortable helping people with DD. To try to find out why all these students and professionals are calling for more DD-centered training, Lee and colleagues conducted a study. They developed a survey to ask faculty at medical schools what kind of DD-centered training they were providing to their students, and they sent that survey to faculty at all 196 medical schools in the United States. So, out of those 196 schools, how many do we think responded to the survey? Only 14. Only 14 schools responded that they provided any kind of DD-centered training. Now, just because a medical school doesn't respond to a survey does not mean that they don't provide DD-centered training to their students. In fact, I think there's an opportunity here for researchers to replicate this study and try to get information from more medical schools. But like the worst case scenario would be that only 14 out of 196 medical schools teach their students anything about people with DD. And then only about one-third of those students at those schools will likely specialize in primary care, according to those physician numbers from the AAMC. You can kind of see where this problem is coming from. The last evidence we found that indicates that healthcare professionals do not get much training to learn how to accommodate patients with DD comes from our own research. We found, after training hundreds of medical students and physicians, that only about 16% report having had any amount of DD-centered training before our training. Our trainees are mostly second and third year medical students and resident physicians in their first through fourth year of training. To me, 16% is not a very comforting number. So, to summarize the problem and get us all on the same page, many people with DD do experience health disparities, in part due to inadequate quality of healthcare, which likely stems from training being uncommon or incomplete. So with this problem in mind, we now can ask one very simple question. If a patient has trouble completing a medical exam, what are healthcare professionals trained to do? Well, they're taught to use restraint. Now, I want to be clear that this part of the talk is not meant to pass judgment on the use of restraint in healthcare. This part is simply to help you understand that restraint is one of the only behavioral interventions that healthcare professionals are trained to use to help them provide healthcare. Now, to help us better understand why restraint is used and how it's used, I found this recently published review by Ostberg and colleagues entitled The Use and Prevention of Procedural Restraint in Children. They identified 288 studies of restraint that included people aged 1 through 18, in which restraint was used in medical settings, during medical procedures, anesthesia, induction, or mild sedation. They classified these studies by date of publication and found an increase in published studies over time, which could suggest that healthcare professionals are using restraint more frequently over time. They also classified these studies by where they were conducted, and it clearly looks like the US is in the lead by far for publishing about restraint than researchers in other countries. The authors also classified studies by what field healthcare professionals were in. And it seems like dentists use restraint most frequently, but physicians and nurses also use restraint pretty frequently also. The authors defined restraint as procedures that contained an element of force to ensure the immobilization of the child. And they went on to categorize typical reasons for using restraint, such as for disruptive behavior, that was in 17 out of 288 studies, for anxious or stressed children, or to safely perform procedures and not cause harm. Now, they found that restraint is used passively using devices, actively with help from a caregiver or assistant, or even pharmacologically via sedation. Ostberg and colleagues did not identify any studies in which the main aim was to show prevention or reduction of restraint. Now, think about what this could imply for the training healthcare professionals receive. I mean, 288 studies of restraint, and not a single researcher or physician, healthcare professional is trying to study ways to avoid using restraint or to use it less often. Ostbring and colleagues also noted that children with autism had a challenging time complying with medical procedures and seemed to be more often restrained due to procedural fear and or inability to rationalize events. The Ostbring and colleagues review also led me to some work by this author, Lucy Bray, and her colleagues. And one of their studies from 2015 had some interesting conclusions. They concluded that the high incidence of holding, restraint is what they mean, suggests that this is a routine element of practice for healthcare professionals. And holding a child is judged as a reasonable harm to complete a clinical procedure or prevent treatment interference. One last thing from Bray and colleagues, only one paper in their review consulted directly with children about their experience with restraint. Children in that paper, done by Snyder in 2004, reported that restraint caused them to feel angry, resistant, and uncomfortable. So, to summarize this, healthcare professionals are trained to use restraint. It's considered to be a reasonable harm, but may cause children to become angry, resistant, or be uncomfortable. And not many, maybe even no researchers are studying alternatives to restraint. Before we talk about our training, let's integrate this new information and see how it complicates the problem faced by people with DD. To retread this, many people with DD experience health disparities due to inadequate quality of healthcare because training is uncommon or incomplete. And healthcare professionals use restraint, which seems to upset patients and could cause them to become resistant to receiving healthcare. And if you become resistant to receiving healthcare, you're going to experience health disparities. So, how are we doing things differently? How are we trying to help? The broad goals of our project are to teach healthcare professionals new behavioral interventions to use as alternatives or instead of restraint. Now, these new interventions should increase the comfort of patients with DD while also increasing healthcare professionals' success with providing healthcare. Finally, we also want to study the effects of our training to make sure it works and also to make sure that it's easy for other people to use. Now, before I describe the behavioral interventions that we teach healthcare professionals in detail, I just want to summarize it. I want to tell you all the interventions before we talk about them. First, we teach our trainees to survey patients before the patients first come in order to learn a little bit about their abilities and about their preferences. We teach our trainees to use visual supports to help patients understand what will happen next. We teach our trainees to offer patients very short breaks and to gradually expose patients to procedures that they dislike, and then also to give them nice things if the patient chooses to continue. And then finally, with regard to our trainees, we leave them, sorry, they finish our training, and then we let them keep these tools to help them remember what they learned. Show you those tools later. So let's start by looking how healthcare professionals can learn about their patients before a visit. To help healthcare professionals do this, we developed a survey based on work by Nicolatis and colleagues. And we teach our trainees to electronically send this form to patients for them to complete before the patient's first visit. Now, I'm sure any of you who have gone to a doctor recently, several days before the scheduled visit, you might receive an email or a text message that asks you to fill out questions and to complete kind of a check-in. We envision that this kind of form could be rolled into that check-in. Now, this info from this form enables the healthcare professional to plan how they could accommodate a patient who might have limitations with their communication skills, to learn about the things that a patient likes to talk about or items that they like to interact with, and to learn about aspects of medical visits that the patient might dislike. The form also instructs the patient or their caregiver to bring in some of the patient's highly preferred items for the medical visit. And healthcare professionals can then use these items with the patient during some of the other interventions we will discuss in just a few minutes. We also teach healthcare professionals to use visual supports to implement a procedure called tell, show, do. Now, for our training, we use this example, but on our training website, we provide other examples for our trainees to download and use. And we recommend to them that they print these things to be poster sized so that they can hang them on a wall in an examination room. So, as an example of how this visual support might be used, the healthcare professional might say to their patient, I need to feel your tummy right now. Feeling your tummy looks like this. And they might point to the appropriate picture. And then might ask, are you okay if I feel your tummy now? Now, we like teaching healthcare professionals about this whole tell, show, do process because we think it could help some patients with DD have a better understanding about what they have to do next, and this could help the patient feel more comfortable. Now, more recently, to make this training even easier to deliver and to make tell, show, do with visual supports even easier to implement, we've also created an electronic version of the visual support that might be easier for healthcare professionals to use than a paper-based version. They can pull this up on a phone or an iPad to show to a patient. During our training, we also teach healthcare professionals to offer patients brief breaks, especially if the patient seems fearful, anxious, or uncomfortable during any part of a medical visit. Now, one thing we noticed that I think is very, very interesting, is that many of our trainees have trouble remembering to offer breaks even after we've trained them to do this. So after talking to our trainees about this, we learned that many of them are trained before our training to try to complete medical visits as quickly and as efficiently as possible so that other patients on the schedule don't experience delays in being seen. Now, this makes sense, but what if a patient with DD is afraid of certain procedures, like, say, blood draws or ear examinations? Now, typically, a person who's afraid of something will do behaviors to avoid the thing that they're afraid of, such as maybe putting their hands up in a defensive posture or moving away from the person or the thing that they're afraid of. So we try to teach our trainees that when a patient does these avoidance behaviors, it's basically the same thing as them giving themselves a break. It's effectively a patient-mediated break. And these patient-mediated breaks might last a long time, especially if the patient is extremely nervous or anxious. So, uh, we also teach trainees that breaks are not mandatory, and that if they offer a patient a break, the patient is free to say no, thank you. And if they say no, thank you, the healthcare professional can just continue right along with the medical visit. And finally, we teach trainees that breaks should be offered frequently, but can be very brief, like only 5 to 10 seconds long. So we think that offering breaks, brief breaks to a patient can give them just a small moment to recoup after an uncomfortable procedure. We think that it could help establish to the patient that they have autonomy during a physical exam, which is very, very important for a person with DD to understand. And we also think offering brief breaks to patients could actually reduce the likelihood that a patient might do some of those avoidance behaviors that I mentioned previously. We also teach our trainees to gradually expose patients to procedures that are disliked, and then to give patients nice things if they're able to stay calm during the graduated exposure steps. To help you understand how this works, on this diagram, we can see the amount of a patient's anxiety on the left. So this patient here is quite anxious to be doing an ear examination. And of course, they may express this anxiety physically by putting their hands up or swatting at the otoscope, or by saying things like, I don't like this, or by screaming or doing even more challenging behaviors. So when patients display these kinds of physical or verbal responses, we teach our trainees to move about 2 feet away from the patient and to just ask them to look at whatever instrument is causing the patient to feel anxious. Now, if the patient stays calm and just looks, we teach our trainees to give them good stuff like praise, um, access to preferred items that caregivers or self-advocates identified while completing that survey, and to offer patients a 5 to 10 second break. Now, the next step after they do the 2 feet away step is to bring the medical instrument a little bit closer to the patient, about 1 foot away. And again, all they have to do is just look at it. Now, if they say calm while looking, our trainee is supposed to give them more praise, more preferred items, and another break. The last step, of course, is completing the procedure. And if the patient completes the procedure, our trainee learns to give them all the same things over again before moving on to the next procedure. We really, really like teaching healthcare professionals how to use graduated exposure because it's a very gentle way to get a patient to complete a difficult procedure. Certainly more gentle than forcing them to complete a procedure. Now, we try to encourage our trainees to try graduated exposure first before they use restraint. Um, as an aside, we also think that graduated exposure might be quite enjoyable for the patient because it results in them getting some things that they like. Finally, to increase the likelihood that trainees will use the behavioral interventions during the training and afterward, we created a pocket-sized reference booklet for our trainees, and we give one of these to every single trainee who we train, and we let them keep it after the training. So I'm just going to quickly show you the different pages of this booklet. We have like a bazillion of these things. We'd be happy to send you some if you all want some. This first page, the purple page, just has information about our training and websites and relevant details about how to contact us or access our funding disclaimer, I guess. The second page really just has information about what healthcare professionals should try to do at the beginning of every exam of a person with DD. And so, for example, like give distractor here is a cue for them to give the patient whatever item the patient brought with them that could help distract them during the medical visit. This page cues patients, or sorry, trainees, to use tell, show, do, which remember involves that visual support that we developed. And here's a general page on what healthcare professionals should do when a patient is doing great, when they're just kind of cruising along with no problem, cooperating just like they're supposed to. Um, we remind our trainees to make sure to give praise and offer breaks, even if a patient looks comfortable. And we give trainees cues on how to use graduated exposure while making sure to give praise, incentives, and to offer breaks after each successful graduated exposure step. And it's a small thing, but we also teach trainees to give the patient any leftover or extra incentives that they might have after the examination is over. Incentive here just refers to like the really high quality toys or items that the person brought into the visit with them. We think that this kind of like bonanza, so to speak, at the end of an exam could accelerate rapport building between the healthcare professional and the patient, and also help the patient leave the visit on a high note. I mean, I think, the patient might even remember like that is the cool doctor or nurse who gave me some really nice stuff after I did this exam with them. And of course, as with our other visual support, we've developed an electronic version of this reference so that our trainees can easily access the reference booklet, even if they don't have the physical booklet on them at that moment. So using all these interventions with patients makes healthcare look a little bit different. I want to show you a short video of what it looks like to use the interventions. Now, full disclosure, this is not a real patient. It's just someone who is acting like a patient might act. And also, whenever a behavioral intervention gets used, I'll call it out to bring your attention to it.
Hello, are you Becca? Hi, I'm Dr. Abby, and I'm going to be doing an exam with you today. First, I'm going to look in your ears, and then I'm going to take a listen to your heart. All right? All right. So, I heard that you really like to play on your phone. Would you like to play on your phone while I look at you?
Yes, please.
That's a distraction item.
All right, awesome. So, first, what I'm going to do is I'm going to take a look in your ears, okay? All right, so that is going to look just like this, okay? Here in this picture. Okay?
Tell, show, do
So I'm
with the
going to take a
visual
look
support.
in your ears.
No.
All right, that's fine. All right,
Graduated
so right
exposure.
now I'm just going to have you go ahead and look at this tool with me, okay? All right, this is the tool that we're going to use to look in your ears. All right, awesome. You did great. Would you like a Cheez-It? Awesome. Would you like to take a break? Oh.
Giving the patient some praise, offering a break, and letting them have one of the incentives that they brought with them for staying
All
calm.
right. Now we're going to take a look at this from just a little bit closer, okay? All right, here's that tool. I'm going to use it to look in your ears here in just a second, okay? Hey, great job. You have another Cheez-It. Do you want to take another break? No? All right, awesome. Let's go ahead. We're going to go ahead and take a look in your ears, okay? And use this tool right here.
No.
Okay, that's fine. You don't have to do your ears today. You're here for something else. All right. Now I am going to use this tool right here to listen to your heart, okay? All right, and that is going to look like this picture right here, okay? I'm going to use it to listen to your heart. Okay. 1,000, 2, 1,000, 3, 1,000. Hey, that was awesome. Would you like to take a break? All right. Well, that is all I have for the exam. So, would you like some more Cheez-Its for doing so awesome? All right, here you go. Well, it was so nice getting to meet with you, Becca. I'm gonna say goodbye and head out.
Bye.
Bye.
Okay, so I've told you about the interventions and even showed you what they look like when they're used. So what are the results of our training program? That's one of the things we set out to try to study. Well, we developed this training and started delivering it to healthcare professionals in 2023. And since then, we've trained over 800 medical students, nursing students, nurses, doctors, and physician's assistants. Our data from the most recent version of our training shows that about 97.4% of trainees expressed increased confidence to help patients with DD. We think that's pretty important because if you'll recall, at the beginning, many doctors and students have come forward and said that they lack confidence to help people with DD, which makes them potentially even unwilling to work with people with DD. So we like that this results in increased confidence. But even better, we like that 94% were able to demonstrate that they could use the skills that we taught them. Now, we think that these results are fantastic for our trainees, and our trainees also seem to like the training based on feedback that they've given us. I'm not going to read all of these things, but some people call out specific procedures they like tell, show, do, or breaking down procedures, which is the same thing as graduated exposure. People liked the exercise or the interactive portions, or they liked the booklet or the video. Um, Last person on this page says that the live role playing really helped hammer in some of the teachings from the video. And we like that too because our training has a substantial role play component. Some more feedback. Again, people just said the booklet was good, the training had solid structure, and it was interactive. People liked the role playing or to be engaged, and they said it was fun. Yeah, some people said that it was fun. They liked learning. Um, so we like that people like it. That's very important to us. The good results of the training and the positive feedback about it has led to some excellent partnerships with various organizations here in Texas. So our training is currently reaching medical students at Baylor College of Medicine's Houston and Temple, Texas campuses, students at the University of Houston Medical College, which is, I think, Tillman J. Fertitta Family College of Medicine. Sorry, it's kind of a mouthful, and students near Dallas, Texas, who attend UT Southwestern Medical College. And we also train many practicing physicians at Texas Children's Hospital's Meyer Center and Baylor's Transition Clinic at the Center for Pursuit here in Houston. And we also conduct a Zoom-based version of this training with physicians at the Children's Hospital of San Antonio, Texas. These partnerships have emerged organically over time, but we're currently trying to proactively develop as many partnerships as we can because the grant funding for this project will run out in September of 2027. And so if this training seems interesting or beneficial to you and you have ties to agencies that train healthcare professionals like nurses, doctors, assistants. Sorry, I'm having trouble talking this evening. We would love to work with those agencies to see if they'd like to integrate our training program into their curriculum. Also, if you think this training could help people, we are seeking additional funding to continue our work past 2027. So if you know of any interesting funding sources or opportunities, we'd love to hear about it. Okay, so remember that the goals of our project over the years were to develop a training that would teach healthcare professionals to use behavioral interventions that are more comfortable for patients with DD and to study the effects of the training to make sure it works. And then finally, to make sure that the training is easy to use. So how easy to use is it? Well, the newest version of the training is something that we're very proud of. It takes only about 1 hour to complete. Now, this was an important milestone for us because we're told that medical students and physicians don't have much time in their schedule to receive extra training. So what do people actually do during the training? Well, the trainees watch a 20-minute video all at the same time in a group, and then they practice the behavioral interventions with each other. Now, in effect, this means that there is no real teacher for our training. The training video describes the interventions that I just described to you. The training video also teaches the trainees how they're going to practice the interventions with each other, and then instructs trainees to form small groups to practice with each other. And then they practice and also collect data about each other's performances and give each other feedback based on that data. So, as a result, the video itself and also the trainees themselves are effectively the teachers. Now, we like this training format. It makes the training very, very easy for other people to use, to take and use themselves without needing us. But that's not the only way that we provide this training. On our website, we have other versions of the training that we develop to accommodate almost any trainee. So this is a little screenshot of our website, and I'm just going to focus on this box that says, I am an individual. That means one person who wants this training, but I do not want to practice. Remember, I said that there's a substantial role play element to this training. That's what I mean by practice. If they click that, the website displays instructions on how to view the training without needing to practice, inclusive of how much time it takes to complete the training, some little instructions to complete some pre and post training surveys so that we can learn how the training affected their confidence to help people with DD and their knowledge about the behavioral interventions, and also has a direct link to the YouTube video that is the training. Some of the other ways that we can give the training are with an individual, one person, who wants to do the training with us in person and be able to practice. And we use this version of the training on a fairly regular basis, especially when the groups are very small, like only one person. We have a version of the training where an individual receives it over telehealth, just like we're doing right now with practice. We're actually able to practice over Zoom. It's not as great, I think, as practicing in person, in a real examination room with real medical instruments. But I think it's certainly better than not practicing at all. This version is kind of what I told you about a few minutes ago, the version where we get groups of people together and they all practice with each other. But we also have instructions for how to run that training yourself. So if you were to go to our website and select this option, it would display a lot of instructions on exactly how to run this group-based trainee facilitated version of this training. That again, you could be there to kind of observe the training and make sure that all of the trainees stay on task and do what they're supposed to do, like watch the video and then practice with each other. But you don't actually have to teach anything. The video teaches everything that the trainees need to know. We also are looking into developing a new format. This is a group-based format done over telehealth. This is something that we think is very possible, especially now that we have tons of great data on the group-based training that we most recently developed. And so we're looking forward to testing this out over the next year or two. Okay, we're near the end now. How can you, as an attendee, use this information? So if you are a healthcare professional, we implore you, please go to our website. Upper right-hand corner has a QR code you can scan to get there, or you can type in the URL that's at the top. Please go to our website and do our free training. Do it without practice if you want, or contact me and let's schedule to do a practice over Zoom. Or if you're in the Houston area, let's meet up so that I can train you in person. Do our free training if you're a healthcare professional. That's one thing that we definitely recommend. Now, if you're an allied healthcare professional like myself, I'm a board certified behavior analyst, or if you're a speech and language pathologist or an occupational therapist or a physical therapist or a child psychologist or clinical psychologist, if you're an allied healthcare professional, we think that it would be good for you to at least understand the interventions so that you can tell healthcare professionals that you interact with about the interventions and maybe even, if you feel comfortable, help them use those interventions. Allied healthcare professionals are often part of interdisciplinary teams now at many hospitals and clinics. And so it's a feasible recommendation. Now, if you don't feel totally comfortable with helping a physician or a nurse use the interventions, at least you could tell the healthcare professionals about this free training. Now, if you're a caregiver of a person with DD or even a self-advocate, you are in a perfect position to help. After all, some of the interventions that I described actually rely on you, like that survey that gets filled out instructs the caregiver or the self-advocate to bring in items from their home into the medical visit. And that can't happen without the caregiver or the self-advocate. So you're perfectly positioned to understand some of these interventions. In addition, like a caregiver knows the patient very well and can directly advise the healthcare professional to use these interventions. So we recommend specifically, if you're a caregiver of a person with DD or a self-advocate, to bring preferred items to medical visits and tell the healthcare professional when and how to use them. We also recommend that you ask them to offer frequent breaks and even maybe watch the video, watch the training video to better learn how to use graduated exposure so that you yourself can tell and show the healthcare professional how to do graduated exposure if they've not received any training to do it. You could bring a copy of the visual support that can be downloaded from our website, or even the electronic version could be accessed on a device that you have on your person. And let your healthcare professional have it so that they can use tell, show, do to better prepare the patient. And especially if the healthcare is willing to do the things that you showed them, and if the interventions help them to better do their job, please link them to this training so that we can officially train them. I have some references. They're in very small print. If anybody's interested in reading the research that helped us to prepare this training, because I want to be clear, none of this stuff is absolutely novel. All of it is built on the research of other people. And so these are those references for those giants whose shoulders that we're standing on. And I want to thank you for giving me this platform to speak with you today. And I'm going to stick around here to field any questions that you all might have. But here's our QR code that links to our website, as well as a URL. And I guess I'll stop talking now.
Thank you so much, Dr. Lehardy.
You're welcome, Amy. Thank you for having me.
Does anyone have any questions?
If you have questions, if you raise your hand, I'm gonna bring the mic around. Thanks.
We have a question. Let me know if you can't hear them, Dr. Lehardy.
Hello, can you hear me?
I think I can.
Okay, it's really great what you're doing, and thank you so much for telling me that there are actually people that worry about this kind of thing. As a parent, just had to restrain our child this morning just so that he could get a blood test. We're kind of in both. But one thing I did want to ask about was related to that blood test was that certain routine medical procedures are somewhat dangerous both for the doctor or nurse and the patient. So what would you say to someone who said, I've got to restrain this patient because they might injure themselves or they might injure me while this procedure is being performed?
That's such an important question because at the end of the day, the recommendations that I just showed to you are just that. They're just recommendations. I'm not a physician. I didn't go to medical school, and And I don't live the lives of physicians who have to do these dangerous procedures on a routine basis. Um, what I end up telling them during our training, because I do get frequently asked a similar question, which is if we try all this stuff, Robert, and it fails, what do we do? To which I often tell them, you really do just have to now go back to your training and figure out, make a judgment call as to whether or not restraint is the thing that you want to do. Certainly, I think that there is a time and a place for restraint, especially if the benefits outweigh the risks of using restraint. And certainly for procedures that are very dangerous, I think it could be one of those situations where the benefits do outweigh the risks, especially if the danger is severe. And so your question is difficult to answer because what we do know about this training, what we are absolutely certain of, is that this training will help some people, but it won't help all people. People who present with significant challenging behaviors. We think that this will fail. And what we think is that they're in need of more intensive intervention than just what a 20-minute video and a 1 hour training is able to give to our healthcare professionals. And certainly those more intensive options do exist in your community for people who do engage in challenging behaviors that would make this training sort of unnecessary or not unnecessary, but impossible basically to help. Um, so I don't think that I actually answered your question, except to say that we always just have to defer to what the healthcare professional ends up wanting to do, because their job is to deliver medical care. And if they make the judgment, if they try these things and fail and make the judgment that to deliver medical care, they must use a more intrusive procedure like restraint, it's actually, I think, not in my purview. It's out of my professional domain to say that they shouldn't or can't do that because again, I'm not a physician myself. So I'm sorry that that answer, it might be unappealing or unsatisfying, and I apologize for that, but it is a very tough question to answer, and I don't know the correct answer for it, to be honest.
Well, I appreciate that you humor the question anyway. Yeah, I did not expect an easy answer, but I just wanted to, I don't know, say that that was my main concern.
I will try to leave you with a little bit of hope. Here in Houston, we do have those more intensive options that I mentioned. So, we have clinics that children or adolescents can go to receive behavioral intervention, behavioral therapy, basically. Um, and that therapy can be very targeted. Like it can be targeted towards the specific dangerous medical procedures that are probably made not dangerous. So I mean, I'm thinking maybe a procedure that involves I don't know, like needle punctures. We would run sessions with patients using fake needles to try to get them to feel more comfortable with the entirety of everything that builds up to getting punctured with a needle. Um, and over that process, we do often find that people can learn to feel more calm, such that they are then able to go out into the community and be able to do or complete these challenging procedures without necessarily needing to be restrained. But unfortunately, that kind of high level of intervention is probably too difficult for physicians or nurses, any healthcare professional to implement themselves. I think that what you're really looking at is a behavioral professional who would need to assist with that.
Any other questions? Okay.
We have more questions.
So, Ali, so I'm very impressed with your study because you're able to train about 800 healthcare professionals and students. That's incredible. because I did a senior study, I tried to interview pediatrician. I did the $200 and for 1 hour interview, but we don't get many people to buy our idea. So I'm just curious, since you are the BCBA, and how do you, I know you work with couple hospital, but I want to ask, do you provide any incentives for your participants? For example, continuous education hours, or you provide like money to attract those healthcare professionals to take your training? Thank you.
I think that I sort of understand the question, but it was very quiet on my end. Amy, could you help me out a little bit?
First of all, she said that she really enjoyed your presentation and the study. And then she wanted to know, she mentioned that she has a grant and she was trying to get pediatricians to participate and was providing, a monetary um, gift. And she didn't get very many participants. And so she was wondering if you provide something similar to people who volunteer or attend your training.
Great question. We do not really. So for the training itself, we actually have figured out a way to, I guess, worm our way so deeply into these institutions that we work with that our training is basically a mandatory part of the curriculum at many of the institutions. So we don't need to incentivize our students or the physicians that we train because they have to do the training as a matter of course. However, I will say that one of the things that we're looking at moving forward is how the effects of the training, like the skills that people learn, how often do our trainees actually do these interventions with real patients? That's something that we don't have very good data on at the moment. And what we found is something very similar to what you've experienced, the person who had this question. People don't want to fill out our surveys to tell us how much they've used these interventions. And so we are getting ready to pivot to offering financial monetary incentives to people who do complete the surveys that we ask them to complete, um, because I think we're running into similar problems as each other. So yes, I think monetary incentives could work, but the question is, are they large enough monetary incentives to actually influence people's behaviors? And that is a big question. We're not sure yet. We don't know what dollar value is going to help people complete our survey.
Any other questions?
Anybody online? Gail Birdie made a comment. She didn't have any questions, but she thanked you, Dr. Lehardy, for being here today. I actually have a quick question. Oh, they can't hear me. Okay. I have a quick question and it just left my brain. Now I gotta backtrack. First of all, I was very sad that Texas A&M was not on that list. So I'm going to work on that. Oh yes, I remember my question. Is there a list or anything like that? Like if a parent wants to know if a local pediatrician has taken your training, is there a list that we can refer to?
Um, that's difficult. The data that we collect from our trainees is completely de-identified. We don't store any data on their identity, no names, no email addresses. And so it's difficult. I mean, we've trained 800 plus people. It's probably somewhere close to like 850, maybe almost, yeah, like 900, probably even close now. Um, but we don't know where those people are or who they are, which is absolutely a limitation of this, but also is kind of required for the IRB that we have to be able to run this study. So it's difficult. I think that you could ask them, obviously, if they've had any specific training, and if they say no, I think that on our website, we have a lot of the materials that I showed you all in this presentation. And even if you wanted to like print some of those materials, bring some of those materials, and if you yourself, as a caregiver, have experience with how these things are implemented, doctors are pretty smart. Like, the 94% of them end up being able to do the things that we teach them with a very high level of accuracy. So even if you just told them like, oh, my child really, really prefers to be offered breaks. So as often as possible, could you offer breaks or even do them one better? Every time you cue the doctor, like, look at me, doctor, I'm going to raise my hand. When I raise my hand, you need to offer my child a break. You could be sort of helping the physician do that stuff, even if they've not directly experienced this. But also you could point them to our training and we would gladly train them. I'm sorry though, we don't keep a database. We just have organizations that we work with.
Well, thank you so much. Thank you so much for being here. We really appreciate it. And I really enjoyed that. It was really simple. Like I didn't have to take any notes. That's amazing. So thank you so much. Thank you for those of y'all who joined us online. And we're gonna say goodbye. But I'm gonna get in touch with you, Dr. Lehardy, and I'm gonna make this happen at A&M. So
I would love for it because I know you all have a medical school.
yes, we do. All right. Thank y'all so much. Y'all have a great evening.
Happy holidays.